the LiveLung ASCO Scholars program. It was held at the American Society of Clinical Oncology's annual meeting in Chicago from May 30th to June 3rd. Our ASCO Scholars are Larry Brooks, Wendy Brooks, Rosemary Conway, Leslie LaChance, Maida Mongemelli, Maggie McCloskey, and Debbie Pickworth. And then we had a fabulous ASCO team, myself, Dusty, Sherry Haynes, couldn't have done it without you, Sherry, and Sinead McLeod-Clemens. We had a booth, and Sherry and Sinead were just stellar at the booth. And then, of course, Elda Rayleigh. For our first presentation, Larry Brooks. Larry, I'll let you go ahead, and if you want to give us a little information about yourself, and then dive right on into your presentation.
My name's Larry Brooks. I'm the husband of Wendy Brooks, who said he was having me. I'm a caregiver for her. I'm actually her husband and partner through the cancer journey that we're both on. We both live in St. Louis, and thank you for the opportunity to attend ASCO, and thank you for the opportunity for me to give a little feedback here. Wendy and I joke around a lot about having our grandchildren over and how that's the best medicine you can possibly have for anything that ails you. Attending ASCO was probably the second best medicine as far as having cancer. I don't know if you can imagine walking into a sold-out baseball stadium and looking around and realizing that everybody there is working to cure cancer. It's an overwhelming feeling of hope. I also want to point out the byline on ASCO, bridging science and survivorship. And I really like the term survivorship. So I'm going to advocate for early detection. The reason I'm so serious about early detection is Wendy and I both had our primary physician insist that we do low-dose CT scans. And probably the fourth year, I guess, that we had done it, we came through flying colors the first 3 years. On the fourth year, they caught something in Wendy that she had absolutely no symptoms for. And it was a really fast-growing tumor, small cell. And we probably wouldn't have known it if it hadn't been for the screening until it was too late. So as far as I'm concerned, the low-dose early detection saved her life. A little background on early detection. The posters that I'm going to present here, there's not unique to this company, but it's unique saying that we need a quicker, more accurate, and cheaper way of testing for cancer than low-dose CTs all the time. For those that don't know, blood-based detection tests, also called liquid biopsies, they check for circulating like DNA from tumors or other molecular signs that you might have cancer. And now with this particular company and some other ones as well, they're also using AI to interpret the results, which adds to the accuracy and the speed at which they can give the results. It's really super exciting, AI. There's many companies working on this worldwide. If you do a quick internet search, you'll come up with 35 to 50 companies working on early detection blood-based tests. They're all pan-cancer, which means they're not focusing necessarily on a single cancer type, but looking for a pattern of cancer. So one test might detect, look for several and find one amongst many. The global cancer diagnostic market right now is at $114 billion. That's companies trying to come up with early detection, $114 billion. Some of the issues of low-dose CT scans is, it requires really expensive equipment. It requires a technician to perform the test, and it requires a radiologist to interpret the test. With a blood test, you need somebody to draw your blood, and then test the blood, and then interpret the results. So before I get into the actual poster, for those that hadn't attended an ASCO or a conference like this with a poster session, if you can imagine, and I might show my age here, but if you can imagine a blue light special at Kmart, they have a certain area of the conference room set aside and roped off, and they have maybe 25 aisles, and each aisle is 30 to 50 yards long. And as you walk down the aisle, there's easels on both sides of the aisle with large 4 foot by 4 foot posters, and researchers standing in front of the posters ready to describe their research when you stop and talk to them. but it's all roped off, and at a certain time, they drop the ropes and people just flood in like a blue light special. It's pretty crazy. The actual poster I picked to talk about was protein tumor markers for AI. As everybody knows that's at this meeting, lung cancer is the number one cause of cancer deaths. In this particular test, they looked at almost 2,000 people with and without lung cancer, and they're checking for 4 key proteins. And again, it wasn't just small cell they were checking for, but it's a pattern within many cancers. What they're proposing to come out, and I guess I should back up a minute and tell you about this company a little bit. That the software itself is called LungCanSeek, and the company is SeekN, and they're actually a European/Chinese company. They do most of their work in Europe and in China, although they do have an office in California and San Diego as well. So that is somewhat of an advertisement for the software in a way, but in a way not. It's getting the information out there and saying, hey, this is going to be available and we need to pursue it. How will we do that? Their particular software, they came up with like 84% sensitivity and 90% specificity and 83% accuracy for all lung cancers, and that's better than any of the blood tests on the market currently, according to them. They modeled it for 9 million people high risk. The false positives dropped by 10 times. And what's really important is the cost dropped from $2.5 billion to right at $978 million. That comes at like $15 a test. If we could get tests for cancers down to $15, $20, $30, especially in the rural areas where we don't have access to specialized equipment and doctors, general practitioners could do a test for cancer that would really increase survivorship and people's lives.
Thank you. Any questions for Larry?
Are any of these blood tests focused on or earmarked for people who have had lung cancer and are in remission, looking for relapses?
No, I don't know the science behind it too much, but I will tell you that from what I read, they're checking for like pieces of the tumor, anything that's molecular, cells that are related to cancer cells that are floating around in your bloodstream. So even if you're in remission and you don't have anything, like you're marked as cured or nothing there, and then it shows up again, then the answer would be yes, I would suppose.
And if I could jump in and amplify a little bit what Larry is saying here, because this was also a favorite poster of mine, and I think one of the really important takeaways for me was that this is a fast test and an inexpensive test. So it will change the eligibility criteria, I think, for people who can be screened for lung cancer. Right now, you have to qualify and be a certain age and be a former smoker to get insurance to cover a low dose CT scan typically, or you have to have other known risk factors. And in this case, if you have the known risk factor of previously having had lung cancer and been treated for it, conceivably an inexpensive test like this could be administered annually to check for recurrence, right? So I think that's one of the big takeaways for me from this, is that it's just so much more expedient and so many more people will have access to early detection through, if not LungCanSeek specifically, tests like LungCanSeek. And so that's super, super important. So I don't know what the plan is exactly for it, but that when I talked with the researcher about it, that's what he was really excited about. He's like, anybody can take this test.
You're absolutely right. And I should have also mentioned that even low dose CT scans come with some radiation exposure.
Right.
So, in this case, the blood test, you wouldn't have to deal with that.
Yeah, and more false positives too. They seemed pretty optimistic about the accuracy of the test. So
If you get a positive with this test, they follow it up with a CT scan. So it's a two.
exactly.
It's very exciting.
Mm-hmm.
Great. Any other questions? Thank you guys and thank you, Leslie, for chiming in. Thank you.
Yeah, I have a question. How soon or when do they think this will come to market? Be available for, doctors in your office, if you will.
I don't have an answer for that.
Oh,
Okay.
yeah, the timeline is a little bit, we don't actually know, but this study was what they call a retrospective study. So it looked at information that had already been collected and looked at the data from that information rather than following a cohort of patients along, into the future. And so they need to do what they call a prospective study first. And so they need to put this test into a trial basically and follow that cohort for a specific amount of time. So I don't know that the timeline is certain.
But there are current liquid biopsies available, I believe.
With the amount of money being spent and that can be made out there currently, the $114 billion in 2023, I don't know what it is now. I would assume that there's a pretty big push to get something out there and in the market pretty quickly.
All right, thank you.
Thank you so much. Thank you, Larry. That was fabulous. Thank you. Okay, I guess we're going to hand the camera over to Wendy. Wendy Brooks was also one of our fabulous ASCO scholars. Let me go ahead and move there. Go right ahead, Wendy. Thank you.
Okay, thank you. And thank you for having me. And thank you for, again, LiveLung for sponsoring us to attend this. It was just amazing. And I'm still reflecting on everything that we learned and saw and experienced. So what I want to talk about, and I'm Wendy Brooks, Larry's wife, and I was diagnosed actually 2 years ago yesterday with small cell lung cancer. So it's my cancerversary. And I really stumbled into a poster presentation about relapsed small cell lung cancer. And when I was initially diagnosed 2 years ago, it was limited stage, and I did all of my treatments with the chemotherapy and 30 chest doses of radiation. And then I went into the surveillance part of my journey. And after 3 months, I had a metastasis to my brain. And then it came back 2 months after that to my lungs. So I was a relapsed SCLC person. And when I looked at this poster, what really caught my eye was that it showed the data came from the university where I was being treated. So that piqued my interest, and then I started looking at what the data was about and realized that I was part of this study. And like I have in my bullet point here, it's like I found my story in a book that I didn't even know existed. Had I not been at ASCO, I would have not known that I was part of research for lung cancer. And I'm just, even now, I'm getting goosebumps because it was just so mind-blowing and what I had hoped when I had signed over my informed consent for my biopsies that were taken, that it could help lead to a cure, that somehow my tumor could help lead to a cure. So this really inspired me to share exactly what this meant. So if you can go to the next slide, Lynn. This is the poster that I walked up upon, and it was, I want to say there was some kind of divine intervention working, because Elda had texted us to say, hey, there's a really good poster from Emory University that I would like for you guys to go see if you have the opportunity. And we did, and right next to it was this poster. And I just started looking at it, and I'm like, okay, it's from Washington University in Siteman where I'm being treated. But in addition, it also has Duke University, which for the last 2 years, attending the Small Cell Summit in Raleigh, North Carolina, we have visited this lab to where these samples were sent for further research. And that was just, again, more goosebumps, because not only was my sample taken from me at my university, it was also sent to another lab that I visited twice that I know is dedicated to finding a cure. So that was my big personal journey within this. But what's really cool about what they're doing is they took treatment naive tumors. So when I was first biopsies to the type of cancer that I had, that I had not had any treatment. When it relapsed and they took another biopsy for me because of a study therapy that I went on, that was my relapsed tumor that had been treated. And they were able to see what had changed. If you can go to the next slide, Lynn. It's important too, because I know that we have folks that have non-small cell, that because small cell is such a fast growing lung cancer, and we have the 2 stages of limited stage where it's only in one lung. So one area, small fire in a room, or extended stage where that fire has spread to other areas. The relapsed cancer comes back after treatment, and because it's learned what we're trying to kill it with, it becomes harder to treat. So let's go to the next slide. So it becomes resistant to that treatment. And a lot of times you'll hear that folks are platinum resistant, because the cancer has figured out, hey, that's trying to kill me. I'm gonna change to where it can't. So figure something out, tough guy. So what they studied was looking at before it was treated and after it was treated, what were those changes? What changed with the DNA? So like you have a typo in a recipe, or the gene activity, what changed? So which instructions the cancer follows, and then how to trick the immune system. That's how the cancer hides. So they studied this from that treated biopsy. You go to the next slide, please. And what they discovered is that there's DNA damage, that the relapsed small cell has these scars from the chemotherapy. And then there's the genes, like the MYC genes, that's the cancer's growth buttons. They figured out that those are overactive. That's what's causing it to continue to spread. And then the WNT pathway, that's the system that helps the cancer grow, that it can continue to go on. And that there's splicing issues as well, that messes up how the genes are read. So similar to if you're reading a book and there's some pages missing, it doesn't make a whole lot of sense, right? But that messes up the targets that they're trying to hit with the therapies. And the cancer can hide from our immune system by boosting CD24. So it's wearing a disguise, it's cloaking itself, and lowering the MHC1. So that's like turning off a wanted sign. So it's like it's hiding from the therapies that you're given. Please go to the next slide. So what they found in the research was that they needed to target the splicing. And how do we fix those genes that are read to stop the cancer growth, and then block that WNT pathway to keep it from, having those growth signals, go ahead and boost the immunity and help the immune system find and fight cancer, and eventually get to personalized medicine and tailor the treatments to each patient, because there's differences in each stage of that relapse that the MIC might be off in one, but it's the WNT in the other. So the real goal is to get that personalized medicine to help your immune system fight this. And what this really did, this research, it's going to lead to better treatments for small cell. So why this all matters is because it is that step towards hope. It shows why the relapsed small cell is so much harder to treat. And again, for me, the personal aspect of this, it was just overwhelming, but also empowering. We know that in the big picture that the new treatments are going to mean longer and healthier lives for us. And my hope is that this work inspires others to keep fighting and supporting cancer through research, because that's how we are going to get to that cure. So that was my big aha moment.
Oh, wonderful. Thank you. Thank you, Wendy.
You're welcome.
Thank you. Any questions?
Wendy, this is Elda. I have a question, and I want to make a point that you signed a release to use that tissue in the research before they shared it, correct?
Absolutely. For both of my biopsies, they asked me to give an informed consent to be able to use that tissue to study and for research. I didn't know what research.
They said they store it for up to 30 years. They're like, really?
So that's a very important step that allowed them to make these discoveries and everything. They couldn't have used that tissue unless you had signed that informed consent. So
absolutely.
And I will say, I remember, it's like yesterday. I remember at the president's dinner, Wendy, when you shared this with us, it was just, I'm getting goosebumps just thinking. It was just, what a remarkable discovery and to know that you've been in Dr. Trudy Oliver's lab. And your tissue is probably in that lab. So that's amazing.
Yeah, there's definitely a mouse with my tumor, I'm sure. I'm sure of it.
Any other questions or any comments, guys? Okay. Wendy, thank you so much for a fabulous presentation.
Thank you.
Yeah, and thanks for doing that. It's
you.
wonderful.
And just as an FYI, if we have any other small cell lung cancer folks here, we do have Dr. Neil Reddy from Duke Cancer Institute, who is last month, Wendy and Maida Mongemelli, who is another ASCO scholar, gave a fabulous presentation on some of the small cell lung cancer presentations. But tonight, Dr. Neil Reddy from Duke Cancer Institute is going to do a deep dive and really make sure he covers everything and answer questions. So tonight at 7 p.m. Eastern time is that small cell lung cancer meeting. And I'll put a chat and link at some point during the meeting. It's hard to share the screen. Okay, next up, I believe, is Rosemary Conway. Rosemary?
Hi, everyone. I'm Rosemary. I'm an almost 8-year survivor of non-small cell lung cancer. And I also want to express my extreme gratitude for bringing me to the ASCO conference. Like I think Wendy said, I'm still processing everything. And I don't think anyone can imagine the amount of material that's put before you when you attend these sessions. And when LiveLung said, okay, we want you to present 3 things, your aha moments, there was like thousands to choose from. So I kind of picked things that I thought might appeal to everybody, as opposed to just going after like KRAS research, which anyone that's interested can look it up. And anyways, so that's why I made these choices. The first one I chose has to do with the microbiome. I've always wondered, when people have immuno and chemo, why does it work for some people and not for others? You know, and I understand, like, regardless of cancer type. So this session focused on the microbiome, basically the gut. So looking at this dysbiosis, that's when the normal microbiome balance in the gut is either has decreased bacteria, increased bacteria, or a loss of diversity, mainly in the gut. One of the things that they brought up, where if you can look at the left, I know the slide's crooked, it's because I took a picture. Key takeaway, antibiotics are causally linked with resistance to immuno and chemo and should be judiciously prescribed. That was an aha moment for me because how often do they put us on antibiotics? No matter what's happening, here's an antibiotic for you. The other thing that is noted is that gut dysbiosis is a risk factor of resistance to immunotherapy. So that kind of makes you understand, oh, so maybe some people don't respond well to immunotherapy because of these factors going on in their gut. And they're saying that you should have this dysbiosis kind of looked at prior to having your treatment, which of course is going to be a long process before they get to that. So I think Lynn found this slide. But anyways, the goal is to identify microbiome signatures linked to cancer diagnosis, treatment response, and prognosis, study how gut bacteria affect the immune system, and reveal how gut dysbiosis can weaken cancer-fighting immune responses. One of the things that I really was interested in is this concept of what can we do about it? And they were talking about further on in the presentation how they can alter the gut biome by sort of chemically creating different stool environment and putting that in patients and then proceeding with treatment. And I thought that that sounded interesting. So this was another one that really interested me. And I know it's not very scientific, as my oncologist told me after when I saw him, and I said, I was so excited about this study about time of day of treatment. And he said, well, this study came from China. And so we're not sure if we can reproduce it. And we would need to make sure that the results are really authentic. However, I think it's important to look at it that with these 210 patients, stage 3C to 4 non-small cell, they looked at whether they would be treated before 3 o'clock or after 3 o'clock. They all got pembro or sintilimab and chemo, and they didn't have driver mutations. Most of them were like in their 60s and male, by the way. So what is astounding to me, and probably to you, is that the group that received their treatment early in the day, they had 13.2 months progression-free survival. The group that received their treatment later in the day, 6.5 months. So they doubled their progression-free survival by receiving treatment before 3 o'clock. I thought that was pretty astounding. They still haven't reached their overall survival. And for the late treatment group, it was 17.8 months. The takeaway, timing matters. Morning immunochemo nearly doubled progression-free survival and overall survival in advanced non-small cell lung cancer. This supports further research into circadian rhythms and treatment timing in cancer care. There were also a couple of other sessions that mentioned circadian rhythms, and I believe that they're going to start looking into that more. And when you think about it, how many people go and get their treatment after work as opposed to early in the morning? And so why is it different? They need to kind of examine that further with more studies. Next. So the reason I picked this is because this person, Stephen Marlin, is a patient advocate. He's actually a PDAC patient, pancreatic survivor. And he was kind of talking about, from his perspective, why are trials important? And he was specifically looking at immunotherapy trials. Patients see immunotherapy as hope. Real barriers exist. There's limited trial access, unclear guidance, and eligibility confusion. Patients can be strong advocates if they're empowered with information and support. Clinicians can guide this advocacy through early testing and proactive trial referrals, which, by the way, doesn't happen very frequently. And together we can push immunotherapy forward for hard to treat recalcitrant cancers. I loved his quote that he put up there. It's an African proverb. If you want to go fast, go alone. If you want to go far, go together.
Any questions for Rosemary?
I'm just curious. This is Leslie, Rosemary, and I'm just curious if they had any speculation other than that this might have something to do with circadian rhythms for those vast differences in the numbers of progression and survival rates.
They didn't. And actually, that question was asked in the session, and they didn't have a great response.
Yeah.
So I think has to be looked at further.
I wonder how they came up with the idea for the study too. That's so interesting. Like, do you just think about it and say, I wonder, hey, let's try this, like.
I know, like, why did they pick 3:00 also as their cutoff?
As their cutoff, yeah.
And is the body's chemistry different before 3 than it is after 3? That makes it more kind of susceptible to immunotherapy and chemo?
Yeah, I know my mood is different.
Well, and what about if you're a night person or
right?
There's so many things that you would think would be variables.
Yeah, it's
I
so
mean,
interesting.
Some of it kind of makes a little sense to me, just be like in the meds that I'm on, one of them you can take in the morning or in the evening.
Mm-hmm.
And a lot of people take them in the evening because there's less side effects if you take them in the evening versus the morning. So there's got to be something to that.
I agree. Same thing with the medication I'm on. I take it in the evening, so there's less side effects. Debbie, you were in this session with me.
Yes.
Yeah. So
yeah, we were both going, that's interesting because I always had my treatment in the morning.
Me too.
Next up is Leslie Lachance. Go right ahead.
All right. So this is kind of on the heels of some of the presentations you've already heard about the importance of, and Rosemary just touched on this, on the importance of getting access to clinical trials. And often patients who might be eligible for clinical trials are not referred by their clinicians for lots of different reasons. And I entered a clinical trial. I was diagnosed with ROS1 positive cancer, and the initial treatment failed me after 6 months. And so I was out of options except for chemo. And it was really somebody in my ROS1 patient support group who influenced me to try to get myself into a clinical trial. My clinician was not interested in referring me to an out-of-state clinical trial. And so I had to do it kind of all on my own through self-advocacy. Most clinical trials, according to this poster session that I came across, most clinical trials globally are not representative of diverse patient populations. And 78% of clinical trial enrollees are white. No matter where those trials are going on, the majority of people who enter them don't represent a heterogeneous mix of patients. So that can limit the generalizability of those studies to broader populations. And there's also an insufficient understanding in that case sometimes of the drug's safety and efficacy between different patient populations. So that actually hinders equitable access to investigational drugs. So these researchers they're not clinicians, but they are data researchers, right? And they are interested in creating a future where there's a more proportional demographic representation across sites, especially in the same geographic area and disease area specialists. So if you've got a clinical trial in a particular city, your patient enrollment should look like the demographic of that particular city or region. And that that needs to be attended to and broaden the enrollment of people with diverse backgrounds in clinical trials. And that needs to be intentional. That work needs to be intentional on the part of researchers. And so that was one of the pieces that got my attention.
How do they think that they can do that? How can they achieve that goal?
That's actually what this consultant was sort of offering, was we can help you create a plan, right? And some of the things could be as simple as making information about the trial available in multiple languages, right? I mean, that's a simple solve, right? If you're especially if you're in a metro area, that's just one example, but I think it has to do also with how the trial is conceived and how patients are recruited, and clinicians having to maybe collaborate with other clinicians and researchers to fill out these trials with cohorts that are more representative of the people who will ultimately receive these treatments. So
Yeah,
I'm not a study
I'm just
designer.
wondering-
So.
yeah, I was just wondering if maybe just, what, I don't know. I just wonder if they can go out into communities and actually.
Yeah, that's definitely part of it, is doing better outreach, working with community groups, patient support groups, working with, hospital outreach and research center outreach offices to try to do a better job filling in those trials and actually having it as a stipulation of what they want in their cohort, like thinking about it, right? It's not, instead of it being just kind of whoever can afford the plane fare to Boston, which, was kind of my situation, right? I could go to a trial in Boston because I could fly on Southwest, right? So, there could be other ways to accrue for trials to accrue.
Okay. Elda, did you want to jump in, Elda?
I just wanted to make a point that it's important for the researchers to be able to have the patient perspective as they're conceptualizing
Mm-hmm.
clinical trials. And a lot of that will happen when we have trained advocates like this group that can actually provide that input in a knowledgeable way. So you can look at a clinical trial protocol so that it can be more patient friendly and see where some of the accrual barriers might be before it actually gets to the point that it's implemented. So just something to think about.
Important for the patient voice. Thanks, Elda. You're so right about that.
Yep. Rosemary?
And I was just going to mention that I was at a conference yesterday where I was presenting on a panel. It was a clinical trials in oncology East Coast or something conference. And I got asked to be on this panel. And I sat in on the session that came before mine. And one of the things the woman was presenting was exactly what you're saying to the group of researchers and technical people, that how important the patient perspective is, how we should include patients from the very beginning of trial development and throughout the trial. And we also talked about that during our session. And I think they're listening to it, and there's a lot of people that are pushing for this to happen, but there hasn't been really a lot of action yet. They're trying to sort of teach researchers how to help make trials more user-friendly, patient-friendly language. And I think part of this whole recruitment issue is huge because 80% of people don't go to large cancer centers. So how do we reach those 80% and get recruitment from that cohort and for people that are of diverse populations? And I think our salesman has to be the oncologist. That's just my perspective.
Yeah, and a simple, obvious thing is the ability to travel, right? I mean, often some patients are too sick to travel, but if they can travel, they might not have the means to travel. And so some of the trial sponsors now are stepping up and paying for that, to
They
fly
are. They are talking about that.
Yeah, but not all, and so I think more effort needs to be put into the economics of getting people involved in trials as well.
Wonderful. Thank you. Leslie, you have one more presentation that you wanted to share. Thank you.
Very quick.
Great
Yeah.
conversations, guys. Thank you.
Yeah. And so I went to a session on survivorship because I am what some people might call a long-term survivor. I was diagnosed in 2017 with metastatic non-small cell lung cancer, ROS1 positive driver mutation. And so I've been very blessed, and I kept thinking about this as I was at ASCO. Like, I'm so grateful to be at ASCO. This was so important for me. And one of the reasons I get to be here is because I've had successful treatment. And so this was a session that really appealed to me because it focused on people who are growing in number, people who live for a long time with metastatic cancer, and what that means for us and for our care specialists. And so we have lots of long-term challenges, and it feels different than sometimes it feels when you're first diagnosed, because when you're first diagnosed, you're trying to figure out that landscape, and there's panic and fear and immediacy there. But when you are a long-term survivor, there are other things that start to be a little more taxing, and things like, that you have prognostic uncertainty. You never know from scan to scan, and this goes on for a long time and creates stress, and you're in treatment typically for life. There's always a change in the disease burden and treatment toxicity burden along the way. A lot of us face financial toxicities like unemployment or underemployment, and some of us take early retirement, which has financial consequences. The healthcare system landscape is always shifting, and we are always having to negotiate changes there, changes in insurance, changes in providers, changes in who owns the hospital system where you're being treated. And we need sources for reliable information that we can understand that comes out of these ever developing situations. The need for psychological, social, and physical support, need for a community of peers. And there are best practices that have been established, but there are no measurements for those best practices really that are robust, whether they're being implemented or not. And really what we're talking about is changing the clinical paradigm for all cancer patients as they enter into survivorship. And survivorship care, the argument is in this presentation, should be an opt-out rather than an opt-in. The assumption should be that you will face survivorship issues, and therefore there should be provisions that are integrated into your care that address those needs. So really just changing the clinical paradigm in that way.
Wonderful. Thank you. Very important.
Could I add one thing, Leslie?
Yeah.
That everything you said is right on point. Also consider relationships with the patient as well. Caregivers and family members living with a fraction of what the actual person has, but they still have to deal with the same type of feelings.
Exactly. Impact on caregivers is a big part of that. And, and families do, and caregivers relationships are strained, right? They need support too.
And then we have Debbie Pickworth. Debbie has two very interesting topics that she's going to share.
Yeah, I kind of picked these because, well, the first one being AI, just because I'm like a little geeky when it comes to technology and stuff, and I found it really interesting. So AI in cancer care. So I kind of just broke it down. There was a multiple the first day on AI, so this is kind of just a little breakdown. So AI is a human augmentation tool. AI is currently best used for human tasks, especially like note taking and repetitive workflow in healthcare, And then, but we need to also consider that it should be complementary towards it, not take over. We should never lose the human aspect. But let's see. And then the ambient AI transcription system, which I'm sure you've all seen, like when you go into your healthcare now, they're like using it for note taking, allowing them to, be more direct with you while they're doing the notes in the background. And then I feel like it improves the patient experience because your doctor is spending more time with you instead of on the computer taking notes. The radiomics and early cancer detection, AI models show promise in radiology, especially for early lung cancer detection and pneumonitis diagnosis. This G and H was an AI diagnosis of lung cancer before lung cancer was seen. So I found that really interesting, that combining it with like an MRI or a CT scan can make early diagnosis of lung cancer be seen before it's being seen. I found that very fascinating. And hopefully something like this in the future will improve patient outcomes. So let's see, the AI-derived biomarkers. AI-derived biomarkers such as TROP2 quantification represent a new frontier in precision oncology. So they're using AI to do predictive biomarkers now. Well, testing anyway, I should say. And let's see, AI-driven image analysis measures tumor-specific interalization and therapeutic agents more accurately than traditional methods, helping to predict treatment efficiency in antibody drug conjugates. So model validation and real-world performance. AI models require careful validation to avoid false positives, alert fatigue, and error tool model hallucinations. Positive hallucination refers to AI perceiving clinically relevant abnormalities beyond human capacity, such as detecting cancer nodules that radiologists miss. So we can overproduce in AI, so we got to be really careful of that so they don't get too many false positives. The limitations and risks for large language models are powerful but prone to generating inaccurate information without human supervision. So again, it goes back to working together with AI and not replacing the human person. Multi-model integration enhances predictive power. Integration of multi-model data in clinical radiology and geographic, sorry, these words are is the key to advancing AI's clinical utility. So why is rigorous external validation important for all AI models? Without broad validation, AI models risk poor generalizability and unintended consequences like alert fatigue from excessive false alarms, which can lead to clinical desensitization and reduced trust. So this one, it was interesting to me, and it's like talked about a lot in the group. People are always asking questions, who does cannabis, and I found it fascinating because I do get nauseous with my treatments, and I've been down the gamut of nausea and the medications and all the side effects from the medication. So I've always found this interesting. So, and the widespread use of cannabis among cancer patients is pretty common, but often occurs without clinical awareness or guidance. So I feel like a structural cannabis history is essential to covering reasons for use, product details, and potential drug interactions. The system level integration is vital. ASCO's guidelines recommend routine, non-judgmental inquiry about cannabis use in oncology care. Evidence-based indications are limited. Clinician evidence most strongly supports cannabis for chemotherapy-induced nausea and vomiting when standard therapies fail. My doctors actually did tell me that it might be an option for me because of all the ones that did fail for me and still fail. Potential risks. The preliminary data suggests possible negative interactions between cannabis and immune checkpoint inhibitors, warranting caution. So again, it's really important to talk to your doctor if you're thinking about using cannabis. And the financial and social barriers, people find it hard to talk to doctors, the stigma of using cannabis, and also financial toxicity of that. It definitely costs more than getting a nausea med. So, that is something else that should be discussed. And then balancing the evidence versus compassion. Evidence-informed communication and respect for patients' anatomy are crucial in cannabis. I'm going to say after I did this, I actually went to a cannabis store, and it was the first time. I have talked to my doctors numerous times about this, and I've never done it and never talked to anybody, about it. So I found this so interesting that I did go talk to them about it, and they went through all the different types for different, like nausea or bone pain or, just inflammation and all this. So I was pretty impressed because in Michigan it's legal. So if you are thinking of doing it, I would definitely bring it up to your doctor. Don't let the stigma of cannabis stop you.
Just a real quick comment. We attended this one as well because we were interested, and obviously don't smoke it.
Yes, that's the first thing I said to them too. I don't want to smoke it. I just want to know about it.
The thing they said about that was you really can't control with the strength or the dose as you can, like if it's an edible or a tincture, you can actually tell what your dosage is, but when people smoke it, you just don't really know what you're getting.
And the other comment is just that it's so hard, since it's not legal everywhere, to actually get clinical trials, to get good data to reflect, does it help more than it hurts? Because there is some data about cardiac.
I was impressed that ASCO put this on and they did some research on it, so that kind of made it easier for me to bring up to my doctor after seeing this.
Thank you. Okay, so I'm just going to share a few photos from the event, and then Elda and I are going to ask the scholars some questions, and you guys feel free to ask questions as well, not necessarily about the presentations that they shared, but anything you want to know about their experience at ASCO. But the picture on the left-hand side here with the beautiful view behind them, that was the very first day when you guys went to go pick up your packets. And you'll see Maida, and then Glenda Mower. She is a member of our Charlotte group, and she actually won a Conquer Cancer scholarship to attend. And we kind of adopted her because they didn't give any training. They were just going to send her off to ASCO and have her figure it all out. And so she came to all of our trainings, and we just were thrilled to have her with us. And then, of course, there's Leslie and Rosemary and Wendy and Larry and Elda. And in the other photo, there's Dusty and Wendy and Dr. Gadgil, Dr. Cherise Gadgil, Debbie Pickworth, who is a patient of Dr. Gadgil, and then Sherry Haynes. So, and this was at the President's Dinner. They always have a big dinner for all of the ASCO attendees. And then I think one of the best things that you guys loved, and I will say it's absolutely one of my favorite things, is I feel like I'm meeting celebrities. Rosemary, you want to share a little bit about your experience? Because I know this was huge for you.
The very first day after we got our packets, we were upstairs because Elda wanted us to know where the patient advocacy lounge was. And then we went out into the hallway, and Nargis Flores comes walking down, and she's like, Rosemary Conway or whatever. And she was so excited to see me, but I was more excited to see her. It's just unbelievable, the people that you just run into in the hallway. And so that was really fun for me.
Oh, I love it. I warned all of our scholars, I'm like, beware, I will fangirl. I'm like, oh my gosh. And then, of course, you see Larry and Wendy here next to our booth. And Sherry, that looks familiar, doesn't it? Sherry and Sinead were at that booth the majority of the time. That's the best thing about that booth, is you get to meet lots of folks. And Sinead McLeod Clemens, she is our social media manager. I'm very fond of her because she's also my daughter. She's with Dr. Christine Lovely, and I'm like, oh, I'm running, look at Dr. Lovely. So it's wonderful. And then over here we have Maida with Dr. Jacob Sands. It's just amazing the way that you get to meet these people that have made such an amazing difference to the lives of so many people.